Greetings and a warm welcome to all the dignitaries present here. I'm Rimpa from Clarnet, serving as a allocated session assistant to ensure a seamless experience. Clarnet proudly stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctor. It is with great pride that Clarnet serves as a judge partner for this event hosted by Karnataka Undergraduate and Postgraduate Ophthalmology Teachers Academy. And the focus of today's session is Online Educational Series Episode 4. Now, I would like to welcome Dr. Soumya ma'am for the further proceedings. Over to you, ma'am. Thank you.
Thank you so much. Good evening, everyone. On behalf of KUPOTA, I warmly welcome all the distinguished faculty members, postgraduate students, delegates, and participants who have logged in from various institutions across Karnataka to today's online educational series conducted in association with the Karnataka Ophthalmic Society. Your enthusiastic participation is what makes this platform a vibrant academic community and reinforces our shared commitment to excellence in ophthalmology education. KUPOTA was established with the vision of creating a structured, statewide educational forum that bridges institutions and promotes uniform standards in ophthalmology training. Through regular case presentations, journal discussions, and expert-led interactions, we aim to provide postgraduates and undergraduates with opportunities to learn from experienced mentors, develop clinical reasoning skills, and gain confidence in tackling both examinations and real-world clinical challenges. It is now my privilege to extend a special welcome to our esteemed chair, Dr. Satish Shet, our distinguished discussants, Dr. Sheetal Savoor, Dr. Vinuta BV, and Dr. Arvind Tenagi, our mentor, Dr. Anuradha, and our presenter, Dr. Tisha Vasant, who have kindly agreed to share their expertise and contribute to today's academic discussion. Today's session focuses on a glaucoma case presentation, a topic of immense importance in postgraduate training. Glaucoma remains one of the most frequently examined and clinically relevant subjects in ophthalmology, requiring a thorough understanding of diagnosis, investigations, interpretation, and management. Through today's discussion, I am sure all of us will gain valuable insights that will strengthen both our clinical practice and examination preparedness. Once again, I welcome each one of you to this online educational series and thank you for being a part of this academic initiative. I now invite Dr. Mahesh Babu to take over the proceedings. Over to you, sir.
Good evening, everyone. A warm welcome to all of you for this first session of KUPOTA. I'll begin with introducing our panel today, and we are honored to have an eminent panel today for the discussion and who will guide us through this academic session. We have Dr. Satish Shet sir from KMCRI Hubballi. Sir is associate professor there. He is a very senior teacher for undergraduates as well as postgraduates. He has like endless list of achievements and awards which are cut it down to fit in that slide. Sir has conducted clinical trials in glaucoma at KMCRI. Sir has won Best Video Award in Anter segment in 2023 AIOS conference. Sir has won Rohit Shetty Best Research Award in COSCON and many other awards in various conferences. And sir has also won MM Joshi overall best paper award in COSCON 2020. Sir, your achievements are endless. I warmly welcome you to the session, sir.
Thank you, Dr. Mahesh. So at the outset, I wish to thank for giving this opportunity to me to chair this session. And I welcome Dr. Soumya, Dr. Mahesh, Dr. Sheetal, Dr. Arvind, and Dr. Vinuta, the discussants, and the postgraduate Tisha and the mentor. So we unfortunately missed out on the previous 3 sessions because we were not having the proper communication network. And now I have requested Dr. Mahesh to provide us with all the future meetings henceforth. And being the scientific committee member of AIOS, it's a great achievement from South and especially from Karnataka. So congratulations once again, Dr. Mahesh, on your achievement. And he has been very passionate about conducting all these postgraduate teaching programs. And let all the postgraduates from the state and even outside the state to benefit out of this particular program. And now I request Dr. Mahesh Babu to continue this session.
Thank you, sir. Thank you so much for your kind words. Moving on, we have a discussion, Dr. Sheetal Saur Madam, who is Professor and HOD at Department of Ophthalmology, Enapoya Medical College, Mangalore. A very cool HOD. I've known her since long time, and I think our subordinates and our PGs would love to work with her. We have next discussant, Dr. Vinita PV is a glaucoma. Madam has done a glaucoma fellowship from a Minto RIO. Madam is currently working as associate professor and glaucoma consultant at KIMS Bangalore. We welcome you, madam. And I
Thank
missed
you.
a welcome Dr. Sheetal madam also, our cool HOD. Next, we have our next discussion, Dr. Arvind Tengi sir. Sir is a professor and former head Department of Ophthalmology at JNMC Belgaum. Sir is also KLE's Eye Bank Director, and Sir is currently holding the position of Scientific Committee Member, Karnataka Ophthalmic Society. Sir has also so many list of achievements I could not fit in a single slide. Just to read out few, Sir is a recipient of MC Modi Gold Medal Award by Mysore University. Sir is a past president of Belgaum Ophthalmic Association. Sir received Best Ophthalmology Teacher Award by 40. But Sir also received Best Community Service Award by Karnataka Ophthalmic Society. We welcome you, sir.
Thank you, Dr. Mahesh and the KUPOTA team for giving me this opportunity and sharing my knowledge with the students. Thank you.
Thank you, sir. Thank you. Next, we have our mentor for the session, Dr. Anuradha A., Assistant Professor and Senior Glaucoma Consultant at Minto Ophthalmic Hospital and Regional Institute. She is also a very good friend of mine since long time. She is holding various positions in Bangalore Medical College and Research Institute, very actively involved in PG programs. She is also a Joint Secretary of Bangalore Ophthalmic Society. We welcome you, Dr. Anuradha.
Thank you, Mahesh. Thank you, Mahesh and Supporta team. It's really nice to be in this forum today. Thank you.
We have our presenter today, Dr. Trisha, final year PG from Minto Eye Hospital, Bangalore. I welcome her also. So without wasting much time, I would like to take the session forward. Over to Dr. Soumya, madam.
Thank you, Dr. Mahesh, sir. And now we would request if Dr. Tisha is ready, we can straight away start with our presentation.
Am I audible, ma'am?
Yes, you
Yes,
are.
yes, perfectly audible. Yeah.
Okay. First of all, I would like to thank everybody for this opportunity because it is such a wonderful platform, and it is very, as daunting as it may seem, it is also a very good opportunity for me to learn how to to test how my presentation is, and to probably relate with other people who also would want to know how to present a case. So I hope I do a good job with under all of your guidance. And I would like to introduce myself. I'm Dr. Tisha. I'm a third year postgraduate from RIO MOH, Minto Ophthalmic Hospital, Bangalore. I would like to present this case of glaucoma under the guidance and moderation of Dr. Anuradha. Can I share my screen?
Go ahead and kindly share.
Is it visible now?
It is shared.
Not
I
yet.
think it should be
Yeah.
visible. Yes,
Now
yes,
it is
yes,
visible.
yes.
Yes.
Please go to this slide shade mode.
Has
Yeah. Full screen, full screen.
No, it's not.
Yes.
Today would be my glaucoma clinical presentation, case presentation. Okay, the patient is a 73-year-old male who is a farmer by occupation from Mandya, Karnataka. He presents with the complaints of diminution of vision in both eyes since 1 year. History of presenting illness. Patient was apparently normal 1 year ago when he started noticing diminution of vision in both eyes, which was insidious in onset, gradually progressive, which also worsened over the last 3 months. This was there for both the distance and near vision, and it was not associated with any pain. The patient gives a history of occasional headache, for which he took over-the-counter medications for a week and he discontinued. There were no other associated complaints. Past history, no known systemic comorbidities. Family history was also not significant. Personal history apparently normal. General physical examination. Patient is conscious, cooperative, and well-oriented to time, place, and person. Patient is a well-built and nourished man. Vitals and systemic examination showed no abnormalities. Ocular examination. Head posture was normal. Ocular posture was normal.
Will we interrupt you in history, or do you want to finish the entire examination?
Anything is
Whatever the what do the moderators suggest?
Sheetal madam, you can interrupt at any level.
Okay. Can you just go back to the history, please?
Yes, ma'am. Yeah.
Arvind sir, is it okay with you if we stop at?
Okay.
Yeah. So, can you just concentrate a little more on the negative histories? What are the important negative histories that you would like to ask here?
I would like to ask history of any redness, pain, watering, history of any double vision, history of any flashes.
Why would you like to ask history of double vision in this particular case?
If double vision in because there might also be cataract, so I would like to rule out any symptoms because of that.
Diplopia, polyopia. Okay, fine. And any else? You said history of trauma is fine. Would you like to ask history of any drug intake?
Drug intake,
because I didn't see that.
No, I'm not specifically. I didn't mention it here, but I did ask for any drug intake, and he had only told he had taken over-the-counter medications for headache. That was all the medication that he had ever used in his life. So that was.
So which drugs do you think are relevant in this case? Which drug might be of particular interest for us when there's a painless progressive diminution of vision?
Any steroid?
Yes. And in what forms do you think steroids can affect the eye?
Topical and or systemic steroids. But
yes. Anything else?
I'm sorry.
In any other route of steroids can affect the eye? Do you think ointments can affect the eye?
Ointment, ma'am, and intravitreal also I would like to add.
Intravitreal. Okay. Okay. All right. So you also mentioned history of trauma. Fine.
I add, ma'am, inhalational steroids also.
Yes, all that you must ask. Did you ask history of asthma?
Yes, ma'am. Yes, ma'am. I did.
Okay. Patient had no history of asthma.
No systemic.
Okay. So just based on history, would you like to give a differential diagnosis?
Just based on history, I would like to, based on the age and all that, I would, my differentials would be cataract. And based on headache, I would also like to add glaucoma. And refractive error also, I would, just based on the diminution of vision, these three differentials, main differentials I would like to put forward.
Which kind of glaucoma are you thinking when you're saying because of headache? You're thinking
more
of
of
glaucoma.
an angle closure, more of like a, maybe he would have had any episodes or acute attacks, something like.
Did you make a mention of colored halos and his other history suggestive of angle closures?
No.
Okay, because if that's your second differential diagnosis, I would have perhaps liked to see that in the history also.
Yes, ma'am. That would actually.
What do you think is the most common presentation of primary open angle glaucoma?
Most diminution of vision.
Is it so? Mostly it's asymptomatic, isn't it? Many a times, patient would not know that condition is there. Here, perhaps it's because of the cataract. Okay. Most commonly, they are asymptomatic. So that is something that we must remember. Hmm. All right. Did you ask history of previous usage of spectacles since childhood?
Since childhood, I had asked ma'am any use of thick
Yeah.
glass or any, but no ma'am. He had only used spectacles for correcting near vision, which also was not very useful in the past year.
Dr.
All right. You can
Felicia,
continue.
can I interrupt for a while?
Yes.
Dr.
Yes, sir.
Trisha,
Yes, sir.
you are thinking in terms of glaucoma, primary open glaucoma. Do you want to have any elaborate history of, spectacle usage, something like a frequent change of glasses?
I'm sorry, sir. I didn't get the whole part. The initial question.
Yeah, has got a relation of frequent change of glasses. The patients are never happy with one ophthalmologist. They flee from one ophthalmologist to another ophthalmologist within 6 or 8 months. This is because of the constant pressure, the degeneration of the suspensory ligaments fail them to have a proper accommodation. So it's very important to ask history of frequent change of glasses, especially in case of primary open glaucoma. And one more point in the family history.
Yes, sir.
Yes. Did you ask the family history of any history of glaucoma in the first degree of relations?
Yes, sir. I did. Yes, sir.
Yes. Though there is no family history of glaucoma.
No, sir.
Can you elaborate something on the family history? How does it, especially in POAG, how it is inherited? You know?
The genetic, like
Yes. Yes.
myoclonus and optineurin. Those are the two genetic defects that I would associate with the primary open angle glaucoma.
You're right. Go ahead.
So one question here. I would just like to know how you ask them the family history of glaucoma.
Ma'am, first, I go forward very directly, ma'am. I ask because many of the patients do know that the parents or the relatives or there is somebody with glaucoma. First, I asked any history of glaucoma, the word I used, and then later on, I asked if somebody developed sudden diminution of vision or sudden if they felt like the eye had become very painful and red and then they stopped, they could
Primary open angle glaucoma.
in just primary open.
Yeah. Yes.
Yes, ma'am. And
So one you could ask is a history of drops, chronic usage of drops, for a long time. And you can also ask how frequently they are using. And if anyone in the family went blind due to glaucoma. So these are one of the surrogate ways of, trying to ask if this family, because very difficult. Perhaps they may not even know it's there. And what would be the risk of glaucoma to siblings? Now, this is an important thing. Do you know what is the chance? If you remember, you can tell. Otherwise, it's fine. Parents and siblings. If you don't remember, it's fine. Around 3.9 times, if I remember right. Okay. More chances that the siblings may get affected. Okay. All right. You can go ahead.
Can I go back to the family history of where do you?
You can continue perhaps from
the ocular examination. Head posture was normal. Ocular posture was orthotropic. Forehead and eyebrows, same level on both sides. Cilia appears normal. Facial symmetry was maintained. The assessment of visual acuity. I would like to proceed with the right eye first completely, ma'am, and then can I switch over to the left? Is that So distance vision for the right eye, which was measured with Snellen's chart, was 1/60. There was no pinhole improvement. The near vision was assessed with the Roman test types, was N36. A color vision, which was assessed through Ishihara test case, could not be assessed due to poor vision. Diffraction under tropicamide at 2/3 meter distance was +3 in the vertical and +2 in the horizontal. Best corrected visual acuity also showed no improvement.
So vision is only counting finger 1 meter.
Yes, ma'am.
Yeah, proceed.
So the eyelids were normal. Lacrimal apparatus was normal, Rho+ being negative and the lacrimal syringing being patent. This is the anterior segment photos for the right eye. Then examination of the conjunctiva and the sclera. Conjunctiva was normal, sclera was normal. Cornea was also normal and transparent. Corneal sensations were present in all the 4 quadrants, and central corneal thickness being 535 micrometers. And examination of the anterior chamber and iris. The anterior chamber depth was Van Herrick's grade 3. Contents were optically clear and quiet. The iris was of a dark brown color with a normal pattern. The examination of pupil. Pupil was single central and 3 millimeters round, which showed which was reactive to both a direct and indirect reflex, and the swinging flashlight test showed no RAPD. Examination of the lens. It was lens was normal in position and shape. It showed transparency-wise, it showed a senile immature cataract with a nuclear sclerosis grade 3 with a posterior subcapsular cataract with a cortical cataract. And the intraocular pressure and gonioscopy. For the right eye, intraocular pressure measured with the Perkins tonometer around 11 a.m. showed 34 millimeters of mercury. Corrected IOP, taking into account central corneal thickness, was 32 millimeters of mercury. Gonioscopy showed using a 3-mirror Goldman lens showed posterior trabecular meshwork in all the 4 quadrants. Extraocular movements for the right eye were free and full. A posterior segment evaluation for the right eye using a distant direct ophthalmoscopy showed a red glow. Stereoscopic examination of the disc with the Vogue 90D lens showed mild haze in the media, mostly due to cataract. Disc showed, which was a normal in size, shape, and the neuroretinal rim actually here, I'm sorry, there was like a slight mistake. There is a superior and inferior neuroretinal rim thinning, ma'am, where the ISNT rule was not followed. The CDR was actually vertically 0.9 and horizontally 0.7, ma'am. The peripapillary alpha and beta zone changes were absent. RNFL defects using a red-free filter was present superiorly and inferiorly. This is the fundus photograph now for the right eye. The remaining of the evaluation, vessels were actually 1.1:3. Bayoneting was seen inferiorly and superiorly with the Lemonnier dot sign present. Nasalization and pairing of vessels was also present. Macula showed a dull foveal reflex. Background and periphery, examined with the indirect ophthalmoscope using a 20D Vogue lens, was normal. For the left eye, coming to the left eye. The distance vision was 1/60. Pinhole showed no improvement. Near vision was N36. Color vision also could not be assessed due to poor vision. Refraction showed, just a second, plus 2.5 in the vertical and plus 1.75 in the horizontal. Again, best corrected visual acuity showed no improvement. The eyelids were normal. Lacrimal apparatus was normal, which was also a Rho+ negative and lacrimal syringing was patent. This is the, sorry if this is blocking. Anterior segment photograph. This is the conjunctiva was normal. Cornea was normal and transparent. Corneal sensations were present in all the quadrants. The central corneal thickness being 530 millimeters. Anterior chamber depth was Van Herrick's grade 3, optically clear and quiet. Iris with having a dark brown color and a normal pattern. Examination of the pupil for the left eye, a single central 3 millimeters round and reactive to both direct and indirect reflex, with the swinging flashlight showing no RAPD. Lens being normal in position and shape, showing a senile immature cataract with nucleus sclerosis grade 3 with a cortical cataract. The IOP measured with Perkins around 11 a.m. was 32 millimeters of mercury, and corrected IOP being 28 millimeters mercury, and gonioscopy showing posterior trabecular meshwork in all the 4 quadrants. Extraocular movement being free and full. Posterior segment evaluation showing a red glow on distant direct ophthalmoscopy, and media showing mild haze with disc shape being normal, vertically oval in shape. and the neuroretinal rim showing superior thinning with ISLT rule not being followed, vertical being 0.7 and horizontal being 0.6 for the CDR ratio. Alpha and beta zone pair changes were absent. RNFL defects were present superiorly. This is the fundus photograph for the left eye now. And this is the vessels. It's actually 0.1:3. Inferior and superior bayoneting was seen. Nasalization of vessels was seen, but there was no bearing of vessels. Macula showing a dull foveal reflex. Background and periphery being normal. Can I come to the summary? Yes, sir.
Yeah.
Okay.
Before that, can you take up some questions?
Yes, sir.
Yeah, regarding examination of this thing. You said about the RNFL defects. How did you examine for the RNFL defects, Dr.
The
Isha?
red filter, sir.
Okay. Can you elaborate what are the RNFL defects?
Sir. First use with a I'm sorry. RNFL defects para. Is that what?
Yes, go ahead.
There is first a diffuse RNFL defects, sir. Then there are localized RNFL defects, wedge-shaped defects, superior or inferior wedge-shaped defects based on whether the glaucoma changes are early or advanced.
Yeah.
It's seen more as a reddish hue, sir, using a red-free filter.
Okay.
Reddish hue. Would anybody else like to elaborate on this? We have so many other PGs, right? Can I ask one of the PGs?
I just want to make a comment that other PGs who have logged in also can
Yeah,
answer. So
they
this is kind
can,
of a
yes,
discussion. So other
yes.
PGs can
Someone
also.
who wants to volunteer, otherwise I'll take a name. Anyone wants to volunteer? Sarah, would you like to try? Dr. Sarah?
Hello, ma'am. Good evening, ma'am.
Yeah, good evening. Would you like to tell us about RNFL defects? Okay,
Yes,
how do
ma'am.
we identify? What do they appear like?
There can be localized or diffuse defects, ma'am. So in red-free filter, you can see a dark area. In especially in wedge shaped, you will be able to see a dark area superiorly or inferiorly, which could be associated with notching, ma'am.
Yes, yes.
And the striations will be lost in the RNFL, like normal striations will be lost.
Yes, okay. So, what happens in late advanced cupping? What would you expect? Would you expect slit-shaped defects, wedge, or diffuse loss?
No, the specific pattern won't be there. It will be diffused, so we won't be able to appreciate much.
Okay, all right.
Yeah,
Nitya, I would like to. Yes,
you can
ma'am.
ask, madam.
No, please. Yeah, please ask.
What are the disc changes you see in glaucoma? How do you like?
This phases I would first there would be cupping, second disc hemorrhages, peripapillary changes.
You can categorize, no? Like
Yes, you can go in a chronological order, which appears first and the last. That's better.
Yes, sir. And first, I would like to. There would be neuroretinal rim thinning. This, if I want to. Neuroretinal rim thinning, mostly for the inferior and superior, which is more common, because then we would have cupping, then we would have disc hemorrhages.
What is the typical cupping description in glaucoma? Primary open-angle glaucoma. You need to say more than just a deep cup, right? Would you like to qualify the type of cupping?
vertical enlargement of the cup, ma'am.
Vertically oval and.
Yeah, and what else? See, you're getting bayoneting sign and all that. What is the reason? What kind of enlargement would that be? Anybody else wants to answer? I can see Karthik, Kavya. Anyone wants to tell us? You should quickly unmute. It's an opportunity to answer.
Bean pot cupping, ma'am, in advanced glaucoma.
Yes,
Yes.
yes. Mm. And Isha, you have mentioned pale something. I saw the word pale. Okay. So, what is the classical appearance of the neuroretinal rim in glaucoma? Because that's very, very important. Is it pink or is it pale? You've written pale pink. Okay.
Yes, ma'am.
What do
In
you
the-
think?
more of a pale liver because of the ischemic.
Why are you saying ischemic? Okay. Dr. Shravani, would you like to tell us what to expect of the neuroretinal rim in glaucoma, typically? Open angle glaucoma. Pale or pink? Okay. So, classically, the rim has to be pink. Okay. In glaucoma, please remember that. Because a pale rim with cupping, shallow cupping, what would that indicate? Would that be glaucoma? So, what are the other causes of acquired cupping?
Vascular catastrophes with a hint.
Kirti, Krishna, Neha, so many are there. Priyanka, you can make it a team effort here. No problem.
In optic atrophy changes, the NRR will be pale, ma'am. In glaucoma, the NRR will be pink.
So, optic atrophy. Okay, what else? What other? Sir has given a clue.
Non-glaucomatous cupping, ma'am. Secondary cupping.
Yeah, where do you get?
Optic neuritis, ischemic, optic neuropathy.
Ischemic optic neuropathy. Correct.
Compressive optic neuropathy.
Compressive lesions. Good, good, good. Okay.
Dr. Trisha,
All right.
capillary, Kestenbaum's capillary counting test.
Kestenbaum, it is Kestenbaum's capillary counting test. Usually, it is used to differentiate the type of optic atrophy. Basically, whether it is because of glaucoma or not, if we count the capillaries which are leaving the disc, and based on that ratio, we tell whether it is glaucoma.
Okay, go ahead. We'll take the next question.
Yeah, what is isn't rule? What is isn't rule?
I sent it to ma'am. So in a normal optic nerve head examination, optic nerve, you have the thickness of the neuroretinal rim, ma'am. So first it is the most thick in the inferior, and then superior, then nasal, and least thick in the temporal zone. So in glaucoma, this rule is not followed because of the damage which is being caused to the neuroretinal rim is not, so the thickness is not the most in the inferior and superior, mainly because there is not much glial tissue which is supporting the axons. So when there is cupping and when there is actually pressure changes, they are getting more compressed. So it is not the thickest in the superior and inferior implants.
Okay, you can go ahead and go to the provisional diagnosis. If there are questions.
Yeah. So I have one or two comments. See, in your examination, okay, first of all, the photograph to me appears as if the AC is shallow, but we could be mistaken. When you look at the way can you go to the image? It seems like it's a bit shallow to me.
Fundus.
Okay, both. Yeah. And besides that, you have not given any negative findings. Okay. So in the beginning, when you examine, you are not aware, is it primary, is it secondary? So there were so many findings that I would expect you to say that it is not present. Okay. So would you like to think and, comment on the findings that are not there, but which are very relevant to the case?
Findings only in the anterior segment or through
Anterior, yeah, you begin with the anterior segment.
any findings that would rule out an
In fact,
angle?
I would expect you to do that right from the lids. Okay. In any case of glaucoma, of course, this lady was not on treatment, but if they give you any history of using medication, then you would pay more attention to the eyelids, eyelashes, etc. Do you know why it's important? What are the changes you would like to see if they were on glaucoma medication and you don't know what that medication is?
Any eyelash, prostaglandin
Yes. What would you see?
more long eyelashes.
Yeah, trichomegaly. And
Hypertrichomegaly. Yeah.
yeah. Anything
And
else?
there is an extra row for lashes also. Is that what you were asking?
No, no, no. Not extra row. You're right, trichomegaly. What about pigmentation?
Pigmentation, and some people who might have had any ocular surface reactions to any one of the glaucoma medications also might have like a thickened lid margin also, if I mean.
Okay. Periorbital fat atrophy may be there on chronic use. So each and everything, it's good to, look for it. And anterior segment, would you like to tell us
Something.
what? Yeah, because it's very important in this case. You must mention it.
The grading one?
No.
Something in the pupil iris.
Findings right from the cornea, iris, pupil. Okay, we'll ask somebody else. Shravani, Dr. Shravani is here. Dr. Neha.
Yes, ma'am.
Yeah, would you like to tell?
Yes, ma'am.
Okay. Tell what are the negative findings to mention in this case, in the cornea, in the iris, pupillary area, on the lens.
Ma'am, glaucoma flecken we can look for, ma'am.
Glaucoma flecken.
That's
Okay, we are talking about open angle glaucoma because all this while the discussion was regarding that. So when it's an open angle glaucoma, could it be secondary?
Ma'am, there can be iris pigmentation, ma'am, which is irreversible, like if they are on PG analogs.
Okay.
So we
What
can look
else?
for if any iris pigmentation is there.
Are you interested in iris pigmentation or depigmentation?
Depigmentation.
What you suspect if there's a depigmentation?
Um,
What type of glaucoma you suspect? Moth-eaten appearance of the iris.
Pigment dispersion.
Pigment dispersion syndrome.
Anything else?
Moth-eaten appearance classically described in which condition? Anybody else can unmute and answer. Yes, pseudo-exfoliation.
There is iris pigment epithelial degeneration. There will be transillumination defects, and there would be patchy iris atrophy also, and it may appear frayed or irregular. And other places where you can also see transillumination defects in the mid periphery would be a pigment dispersion syndrome, and in case of iridocyclitis uveitis, secondary glaucoma, you would have patchy atrophy of iris, and the texture of the iris would be lost. The trauma in secondary, there would be focal iris defects.
You'd also look for pigmentary changes on the endothelium. Many a times you might find endothelial dusting in many of these conditions. Okay. What is the classic age profile of patients with pigmentary glaucoma?
It is a more
Like,
stated mostly males around 20 to around teens to the 20s now. That is like the usual age category. So second to third decade.
younger males may not be that young. Okay, so this is a 73-year-old lady, especially pseudo exfoliation. You want to look for it. Okay. Do you find any changes in the lens capsule in pseudo exfoliation?
In pseudo exfoliation, it is there, not in this case. No? Any targets, any deposits present, or any
All right.
anterior capsular opacities that are.
Yeah. Yes.
So even in your gonioscopy, you should have mentioned regarding presence or absence of pseudoexfoliative material, commented on also the pigmentation of the trabeculum issue. Okay.
Or any other materials which are present, which are unduly seen. So you have to make a mention of that.
Yes.
Any proliferate membrane, etc., etc. Okay. And your fundus examination, I would have been more happy if it were done with the stereoscopic examination of your fundus examination, especially the optic disc.
We did try, sir, but the thing is, he has cataract. So everything kept reflecting back. So we actually did try with all of that, even with the visual field or even with the photograph or with the 20D lens, we did try, but the media was too hazy. So that was the
With the
So
90
you mentioned,
yeah, more I mean, easy for even recording and keeping a record of that and using it for its prognosis, which is very important.
Actually, you mentioned mild haze in your finding. So it came to my notice because when you say mild haze, you're describing all the fundus finding and your vision is only counting finger at 1 meter with no improvement in pinhole. Okay, somehow, you should see that all your findings corroborate. Okay. Yeah, otherwise for small things you will get caught and then answering that becomes difficult. Okay.
Continue.
Yeah, please continue.
Summary, can I?
Yes.
So the summary is a 73-year-old male presented with the complaints of diminution of vision in both eyes since 1 year with headache that worsened over the last 3 months. On examination, vision in the right eye was 1/60 and left eye was 1/60. Slit lamp examination showing both eye cataractus lens with intraocular pressure on presentation was 34 and 32 millimeters mercury, respectively. Gonioscopy revealing an open angle in all 4 quadrants with no evidence of PAR. Then a disc evaluation with a 90D revealed right eye 0.9 CDR with the concentric neuroretinal rim thinning with bayoneting and nasalization of vessels, while the left eye CDR showing a 0.7 with the superior neuroretinal rim thinning. Provisional diagnosis being a right eye primary open angle glaucoma with advanced cupping with senile immature cataract grade 3 nuclear sclerosis with a posterior subcapsular cataract with cortical cataract. Left eye being a primary open angle glaucoma with senile immature cataract with nuclear sclerosis grade 3 with a cortical cataract. This would be the visual fields. So the thing is, first of all, I would like to say that the visual fields are not very reliable due to the presence of cataract, but we did do it so to have like a documentation and to see how it would improve after removing the cataract or after a surgical management. Yeah. This is the OCT. So the signal strength is pretty poor. It is 4 and 4 for both. So this is also not very reliable. This is just for the case presentation. We ideally don't do it for this grade of. So we would like to have like a record of all of this, and the plan and management would be for a first we would proceed for a right eye phaco or an SICS for a.
Just a second. Can I come to the diagnosis? Are you happy with what your diagnosis is? With such an advanced glaucomatous damage in the optic nerve and reduced vision up to 1 meter, Or you just want to just put it as a primary open angle glaucoma, or you want to just qualify it in something else? If I would have gone with glaucomatous optic neuropathy, that would have been a proper this thing, because of the glaucomatous changes, and already the damage is set in and the maximum damage has already taken place. So you can add that word with the glaucomatous optic neuropathy would be a proper this thing.
Yes. Yes.
Yeah. Go ahead.
Yeah, go to the visual fields, no? So this visual fields was taken before surgery. Yeah. What is the minimum vision required to do the visual fields?
Counting fingers 2 meters.
Pardon?
Counting fingers 2 meters minimum, but he had only counting fingers.
Minimum required is usually up 6 by 60. Below that, no, usually we don't do the visual fields. Like it will not be reliable only. And counting finger 1 meter is very less, no?
So the results may not be that reliable.
Yes, sir.
With all these odds, because the hazy media, counting fingers less than 1 meter, what madam is saying, you cannot rely upon these fields very exactly. Okay.
What are the typical visual fields findings you get in glaucoma, open angle glaucoma?
Typical visual field changes would be just arcuate, paracentral or arcuate scotoma.
Before that,
Generalized depression of visual field.
yes.
Then in the early stages?
Jerem's scotoma, bearing of early visual field defects, paracentral scotoma, then have a sedal scotoma, nasal step, then arcuate or Jerem's scotoma, and in moderate you would have basically enlargement of the already existing scotomas. You would have like a double arcuate scotoma and a ring scotoma. And in a more advanced case, you would have tubular or tunnel vision. And you would have like a temporal island, which is residual peripheral vision. Then
Why is there's tunnel vision till the end? Sometimes it could even be 6.9, 6.6 if the lens was clear. Why do you think a patient of glaucoma has tunnel vision? What is the reason?
because of the fibers that are affected and the fibers which are last to.
Which fibers are the last to be affected?
Macular fibers.
You're right, you say it loudly, confidently.
Macular fibers, they will be the
papillomacular bundle. Okay, they are relatively resistant to glaucomatous change.
Yes.
Can you tell me something about this Rene's nasal step? Why do you get it?
Nasal step of Rene, there are like defects in on the horizontal meridian. There is an unequal damage basically for either in the superior or inferior arcuate fibers. So it forms like a step shape.
Yes. So why does it happen? What is the anatomical reason for getting this Rene's nasal step? Are you convinced it's based on some anatomical?
Because of the raphe, ma'am, the raphe fibers arrangement is not it is not symmetrical. So because of that, the damage also is not symmetrical. So it forms like a step.
Do they cross the raphe, the fibers, arcuate fibers? Do they cross the raphe and go to the opposite side? Or is it like a barrier?
They don't cross, ma'am. There is simultaneous damage which is happening both
There's a
sides.
differential in the sensitivity.
There is like in scotoma also, there is like a simultaneous damage. It doesn't actually cross and
How do the glaucomatous visual fields differ from neurological fields?
what the ones which I specified now, like those are the typical glaucomatous neuro, the visual field changes, which is not very common in neuro-ophthalmic. Vertical meridian is something which you would pay more attention to in the neuro-ophthalmic visual field effect.
Can you get arcuate scotomas in other conditions also? Or is it just very, very specific to glaucoma? Anyone else also can answer. Kirtana, Kirti, Neha, anyone? Shreya,
ischemic optic
AON.
yeah. AION. Okay, sometimes. Anything else? Any vascular occlusion?
Branch retinal artery occlusion.
Yes. BRAO also you can get arcuate defects. Okay, so it is not only very, very specific to glaucoma. You could get it in other causes. Mhm. And assuming that this field was reliable, okay, and you plan the patient to take up the patient for surgery. Okay, first of all, are you satisfied or would you like to do another field when you see a picture like this on, is this 30-2 or 20?
No,
This is 30-2. Okay. Assuming this is 30-2, would you like to repeat the visual fields? Or what kind of visual field you would like to do and why? And what is its implication on surgery?
I would actually like to also do a 10-2 visual field assessment.
Okay.
I would like to repeat it. So that usually tests the central 10 degrees. It is more specific for detecting a glaucomatous defects. And
Yes. And suppose there was something similar appearance on a 10-2, then
we
does
had
it
the
have
same.
any implication on your surgery? Anyone else can answer? Kedar.
We want to look for macular split, ma'am, in 10-2. If
Yes.
macular split is present, surgery is like it's not going to useful.
Is it so? Is it surgery is not useful? That's not right. Anyone else would like to attempt this? Priyanka. Ravani?
Snuff out phenomenon we have to explain to the patient.
Yeah, the risk of, yes. So, and she said she would prefer to do macular field for this, right? So, what is, or a 10-2? Why do you think that is better than 30-2 or a 24-2? Why does it give you additional information? Why would you prefer to do that?
Because it tests central 10 degrees of visual field.
What else?
And it detects early papillomacular involvement.
What about the spacing? The distance between
Yes,
the
ma'am.
points?
There are only 2
Yeah.
degrees apart from each other, the points.
Tisha, you wanted to answer.
The defects are most likely missed on a 30-2, which you can find more well defined in a 10-2.
Yes. Okay. Manuta, ma'am?
Yeah, based on visual fields, no, how do you classify glaucoma, like the severity of the glaucoma? You told advanced in the diagnosis.
Mild, moderate, and categorized as a more advanced disease based on visual fields. And like you, should I elaborate?
Yeah, mild means
Mild is
mean deviation.
Mean deviation less than -6 decibels, ma'am, and then from 6 to 12, you count it as a more moderate effect, and then more than -12, you would find it as an advanced.
Okay. Then what is target IOP?
Target IOP is basically the IOP which needs to be maintained below so that specific for the glaucomatous damage that has already occurred for that eye. That is the IOP that should be maintained to prevent any further damage to the axons. So basically your normal IOP is from 10 to 21, which may not apply as normal for a patient with already pre-existing glaucomatous damage. So that pressure also, which is considered generally normal in a regular patient, a regular person, would be too compressive or damaging for a person with already pre-existing glaucoma. So the target IOP is basically the IOP that needs to be maintained. So there is no further damage due to intraocular pressure.
So what is the general rule we usually follow for mild cases? How much reduction, moderate, and severe?
Mild in the we usually keep around early glaucoma, you find around 20 to 25% you reduce from the baseline, ma'am. But moderate is around 30%, and severe or advanced glaucoma, you have a 40 to 50% you have to reduce it from the baseline.
Okay. So when do you repeat the visual fields? If it's a mild case, like mild to moderate, or in severe cases, advanced cases?
Do we repeat the visual fields?
Yeah. Follow up, no, during the follow up.
Mild to moderate, because you need to see the progression.
Yeah.
Visual field, you need to assess what the progression might be also. So you would like to repeat better in a moderate case rather than an advanced. But here it is an advanced sort of.
We do in all the cases, no? Like what is the duration we usually keep, like annually or once in 6 months or something like that?
Once in, like yearly we do once a year.
Yeah, that is for the mild to moderate. Whereas advanced we tend to do more frequently. Because target IOP, it is not a, we have to fix it, no, depending upon the progression.
Six months would
Yeah, 6 months or sometimes even more frequently also we tend to do, especially it is very advanced. But mostly 10-2.
Coming to the management, what do you mean by maximally tolerated medical treatment in glaucoma?
maximally maximally medical treatment.
Tolerated, yeah.
Medical treatment that can be tolerated in use. It is use the maximum tolerated combination of anti-glaucoma medications, ma'am, to control IOP before you proceed to a surgical or laser-based treatment. So you use three different varieties of anti-glaucoma medications. And even under that, there is no IOP control, or there is the progression is rapidly increasing, then you consider that MMT has failed.
So we'll
And
give a bitoxolol, cartelol, levobunolol, 3 drugs, 4 drugs. So would that amount to maximally tolerated medical therapy? Timolol, betoxolol, levobinolol, cartolol.
Different, not from the same category, ma'am. Like one from
Different classes of drug and their mechanisms of action should be different, no? Isn't it? That is important. Okay. So which are the different classes of drugs?
different classes.
And how do they work? Yeah.
Prostaglandin analogs, ma'am, beta blockers, alpha 2.
What do prostaglandin analogs do?
Prostaglandin analogs, they increase uveous scleral outflow, ma'am, and beta blockers, they reduce aqueous outflow, and carbonic anhydrase inhibitors also, they also reduce aqueous production. Then you have neotics, ma'am, like pilocarpine.
What about brimonidine? What class of drug is it?
Alpha 2 agonist. Alpha 2 agonist, brimonidine and aproclonidine, they are alpha 2 agonists. Then beta blockers, you have timolol, cartiolol, metoprolol, but mainly timolol.
Are there any drugs which increase the trabecular outflow?
Increase in trabecular outflow, parasympatho mimetics, ma'am, and non-selective alpha agonists increase.
Newer drugs? Any newer? Anybody can help her?
Rock kinase inhibitors.
Yeah.
Netarsudil.
Netarsudil and rapacidil. Okay. What is the side effect of brimonidine?
Allergic.
Yes. So it has happened that patient starts using drops, comes with redness, and he'll be put on anti-allergic olopatadine and sent. Okay. So one is you have to counsel them before, and then you have to know what is the reason, and if it's bad, then you can change the class of drugs. Okay. So it's good to know the important side effects. In whom would you like to avoid beta blockers?
Asthmatics or children less than 2 years, people with hypotension or apnea.
What kind of arrhythmias? Tachy or bradyarrhythmias?
Bradyarrhythmias.
Bradyarrhythmias you would like to. Actually, there are a lot of side effects of timolol. Anything it does to the corneal sensation on long-term use?
Reduced corneal sensation.
Yeah, it can cause corneal hyposthesia. Okay. Arvind sir is used. Can't see him. Should we continue or Soumya ma'am?
Yeah, ma'am, I think we can end by, if you want to ask 2-3 questions about the surgical management, I think that will complete the...
Yes.
If Dr. Tisha still wants to get, or others also, I mean, there are so many postgraduates who have logged
She
in.
may be tired.
Yeah, that's what.
Anybody
so probably
else?
we can have some 2-3 questions on the surgical management, and then I think we can just wind up so that we'll comprehensively finish the glaucoma case.
Anyone wants to attempt answers on surgical questions, please unmute. Sarah. Sarah's here?
I think, ma'am, you can ask the questions, and then probably I guess they could unmute.
All right. So, what kind of surgery would you like to plan for this patient? What kind of a surgical management?
Combined procedure, because he has a visually significant cataract also. So I would like to tackle that along with the glaucoma surgery. I would actually prefer a conventional method, which is like a trabeculectomy with mitomycin. So a triple procedure is something that I would like to put forward.
Okay. So, how does why would you like to use mitomycin C? How does it help?
Ma'am,
And yeah,
mitomycin C basically increases the chances for, efficiency of
but
the
how?
an anti-fibrotic antimetabolite, ma'am. It is used to reduce the post-operative scarring and it improves the bleb survival, which is key importance in trabeculectomy surgery and main causes of failure also. Because there might be subconjunctival hemorrhage or there might be episcleral scarring, ma'am, that they would like to avoid by using mitomycin.
What are the intraoperative ways of using mitomycin C?
Intra of mitomycin C, I would
How is it applied? And what is the concentration and time?
in after create like basically after the dissection, ma'am, like the conjunctival dissection, we have these uh, MMC soaked sponges that
Sponges.
we would keep
So you
under
can apply directly on the sclera. Can you also inject it into the subtenon space?
into the subtenon space,
Conjunctival.
directly into the subtenon space, ma'am.
Yeah, that is also done. Okay, both can be done. So you must know advantages and disadvantages of limbal based versus a phonics based flap, a triangular flap versus a rectangular flap, and same site versus two site surgery. Okay, these are some of the questions that you can expect. Also, the concentration you didn't mention, duration and concentration are important. And what happens if you, use it for too long or too strong? What is the complication that we are worried about?
Ma'am, there might be bleb thinning, ma'am, and the concentration usually used is 0.2 milligram per ml for 2 to 3 minutes, or 0.4 milligram per ml for 1 to 3 minutes, ma'am. And we irrigate it copiously to reduce extra toxicity, ma'am. There might
What
be
is the scleral complication?
scleral necrosis, ma'am, melt.
Thinning can happen. Yeah. Okay, that is something to keep in mind.
What is the other drug used along apart from mitomycin?
5-fluorouracil. That is also something that is also one of the antimetabolites used.
And it can be used even post-operatively also we use it, filling bleb.
That is around 5 milligrams, ma'am, 0.1 ml per 50 mg per ml. That is for that is like the 5-fluorouracil dose that you used in post-op.
What's the role of iridectomy in trabeculectomy surgery?
Iridectomy, usually they might, after we create that window, ma'am, there
Inner
to
ostium.
you to prevent the incarceration of iris or the block of that ostium by that iris, you usually
Yes,
do
good.
iridectomy.
Yeah, so it's a classically a broad-based triangular iridectomy. Okay. And post-operatively, when you assess this patient, you must always look for the patency of the ostium. If you find that the bleb is not working, you must definitely have a look at it. Of course, not very early in the post-op period, but little later. Okay. Mhm. I think it's fine because we can go on and on with questions. They will never end.
Yeah, I guess glaucoma is something which could be discussed
Yeah.
day long, and still we
Yes.
do end up with having a lot of questions though to ask, I guess. And
Yeah.
thank you so much for this exhaustive academic session, which started from basics and systematically, stepwise, probably accelerated to the medications and as well as the surgical treatment. And I hope Dr. Tisha has had a kind of a mock exam in glaucoma, so that if she gets a case in glaucoma, I guess she would remember each questions and answers. I think that's, I mean, most commonly glaucoma is one of the long cases that's kept for the exams, and I guess should really remember each and every discussion that went on in this session. and I would just ask Dr. Mahesh to take over, and I would ask all the discussants to just give quick comments on this and how they felt, I mean, being involved in this session, and what is their, I mean, probably what would they advise the postgraduates as a take-home message. A quick comments from each of you.
Uh, Madam, before comments, I would like all of you to please switch on the camera. Tisha, you can please stop sharing. We'll go for a quick screenshot. And then we'll move on to the comments by our chair, discussants, and mentor. Yes, please.
Hello, yeah. This was a very wonderful presentation and a lot of take-home messages for all the postgraduates to work up a case of glaucoma. But one thing I would always like to highlight the young postgraduates is about the assessment of the optic disc. So there was a scale developed by Dr. Spate in the year 2002, the disc damage likelihood scale. Okay. When you have got an advanced glaucoma of saying about 0.7 or 0.9 that was described by Tisha, so you should assess the discs as per the Spate's classification, and you can identify the extent of the neuroretinal rim at its thinnest location. And sometimes the patients who have large disc, they, even though the cup disc ratio appears about 0.8 or 0.9, but they do not have a significant glaucomatous damage. So assessment by this particular likelihood scale, this damage likelihood scale, you can remember the mnemonic, DDLJ. Okay. So yeah, same way you can remember this TDLS. So always keep the chart next to you when you want to assess these discs. So sometimes inadvertently you may not be requiring the glaucoma surgery for these patients once the cataract has been operated. And it's always better not to use the antimetabolites in the first sitting of the trabeculectomy. You can rather still wait for the cataract and the trabeculectomy to be done, and then repeat the visual fields, and then consider reuse of antimetabolites, because the antimetabolites come with its own set of complications. And since this is a virgin eye, so the cataract could be a significant factor which will be affecting the vision. And I would rather consider cataract and trabeculectomy in the first sitting, and use of mitomycin if necessary for a resurgery. So I will leave it to the discussants to to elaborate on this and give their opinion. Dr. Sheetal?
Yeah, actually, that's a very good point because you did not comment on the size of the disc and the cup, that's very important. So, and this damage likelihood ratio is usually in the early glaucomas when it's a suspect, that's the time to use it. And one overall suggestion I would give you is you have to concentrate on the negative findings, right from the history to examination. Okay, that is something to improve. And I would congratulate you, taking part. It's very easy to do it, in your own small setting, but to come on a platform like this, I think it requires a lot of courage. So I would like to congratulate you for taking up that challenge and doing well. All of us have been in the field for many years, so it's very easy for us to ask questions and expect so much. But you're a newbie, so you have done well. And yeah, and I think the organizers, I think it's a great initiative because other states have been having it, and you have given both the faculty and the postgraduates, a chance so that it's a level playing ground when it comes to their final exams. It's going to be very useful knowing the different perspectives, different ways in which same questions can be asked. So, and thank you for this opportunity. Yeah.
Dr. Vinuta. Vinuta is one of my best friends. We did post-graduation together in MMC. Your comments, please.
Yeah, the case presentation was good. She did it really well and answered also well, in spite of being here. Like it is quite tense moment for her actually. And and thank you for the opportunity for giving me like this opportunity. And it is a nice initiative.
Thank you. And Dr. Arvind Tenagi sir, I think he's not, I think he's traveling, he said, no? Dr. Mahesh Babu sir? I think he's
Yes, sir is traveling. I think
let us
sir is
ask Dr.
still
Anuradha. Huh? Yeah.
online. Sir, Arvind sir, if you can hear, just one or two closing remarks from your side, if you're online. I think
don't think
sir.
he's. Yeah.
Dr. Anuradha, over to you.
Thank you, Dr. Mahesh and Soumya. Actually, thank you all the discussants because I felt whatever questions you asked, it makes our postgraduates feel, one, they have to go through, and two, the confidence with which they're answering. I feel it will take them a long way, and they know that these are really important and what to concentrate on and how it can go. As you said, of course, it acted like a mock test for her, and I'm happy that a chance was given to one of our candidates, and she could represent the other postgraduates of Karnataka. I'm sure in future many more will come on the platform. Thank you.
Thank you. Thank you so much. So thank you all. Now over to Soumya madam for concluding remarks.
Thank you, Dr. Mahesh. As we come to the end of today's session, my privilege to propose the vote of thanks, and I sincerely thank our chair, Dr. Satish Sheth, for his valuable presence and guidance throughout the session, and my heartfelt gratitude to our discussants, Dr. Sheetal Saur, Dr. Venuta, and Dr. Arvind Tenagi, for sharing their insights, guiding the deliberations, and enriching the discussion with their expertise. Special thanks to our mentor, Dr. Anuradha, for helping, guiding, and hand-holding her student in translating this case into this particular session, and it was a meaningful learning experience for all of us. And a special word of appreciation to Dr. Tisha for the excellent presentation and for confidently sharing the case and to be with us for the past 1 hour and all the discussants were giving her questions without any break probably, I guess, and then she really managed to answer all the questions and with a smile on her face till the end of the presentation. And thank you so much, and all the best for you. And I would also like to thank all the postgraduate students who actively participated and participants who have joined us today. So your enthusiasm is a
Dr. Soumya, sorry, I'm traveling. I'll leave the comments online. I'm
Yes, sir,
already in the
please.
metro.
yes, sir.
Thank you.
Thank you.
Thank you.
Yes,
Thank you
sir,
so much.
please.
Thank you. So your enthusiasm and your active engagement is the driving force behind KUPOTA. So my sincere thanks to the Karnataka Ophthalmic Society for its association and for the support and encouragement. Finally, last but not the least, I think I extend our gratitude to our digital partners, Clarinet, Ritu and Rimpa and Swastika, for ensuring smooth execution of today's session and having helped us plan this session from the initiation, from the flyers to the session. You're all of great support and constant support for us and since the inception of the academy. Thank you all for your time, participation and commitment to learning. We look forward to meeting you again in the next KUPOTA session. Have a wonderful evening and thanks once again. Thank you all.
Thank
Over
you.
to you. Yeah.
ma'am.
Thank you.
Thank you. Thank you. Clarinet, over to you, Rimpa.
Rimpa, over to you.
I hope Tisha gets long case glaucoma in her final exams.
Thank you so much, everyone, to have been here and made this session. Thank you so much.
She presented really well. Excellent.
Yeah.
Rimpa, are you there? Should
Okay.
we conclude?
Yes, sir. Yes, I'm there.
Yeah, yeah,
So
yeah,
thank you so much, everyone, for joining this session. Clarity is really glad to have all these brilliant people together. So with this, we are closing the session today and looking forward to hosting you again, sir. Thank you so much.
Thank you. Thank you
Have a
so
good
much.
Thank
night.
you
Good
so
night.
much. Thank
Thank
you
you.
all.
Thank
Thank
you.
you.
Thank you.